Now I would like to call upon the stage the second speaker of the session, Dr. Hashmatullah, who is Assistant Professor of Medicine, Lady Reading Hospital, and he will be presenting the MRI epidemic for low back pain. Are we falling into a trap? Sir.
Bismillahirrahmanirrahim. I welcome all of you on the behalf of the Pakistan Society of Physicians for this great, wonderful conference. Excuse me, can you help me? This, sir? Next. A very common disorder like low back pain. Why this topic has been selected? I know all of us come across a patient like this with a low back pain in our medical career. The main objective of this presentation is to know about are we using the MRI in a proper indication? Are we overusing it? So the MRI for a right patient in a right indication, and there should be a rationale for the use of the MRI. So are we overusing it or not? So I will briefly go into the detail of understanding the low back pain. As we all know, this is a pain from the lower lumbar area, lumbosacral and the sacroiliac joint, and it was one of the most common disability globally. Cause of the disability and the most common symptoms of 60 to 80% of patients who are presenting to us in the primary care setting. Is the most common cause of sickness-related work absence and the condition which is associated with the highest years lived with the disability. The exact cause is often difficult to diagnose, and it's a multifactorial, and the main key is the history and examination. And probably this is the most important thing that we are lacking, either because of the lack of the time or because of the too much patient, or neglecting some of the very serious complaints of the patient by saying it, the patient may be saying it by the way. So the main purpose is either to differentiate the self-limiting disorders of acute mechanical back pain from serious spinal pathology. We need to take a very good detailed history and examine the patient. So our main focus of this presentation is the importance of the history and examination, and as well as a proper indication for the use of the MRI as imaging technique. The differential diagnosis, as you all know, is mechanical, is maybe a non-mechanical, and maybe a visceral pain. These are some of the causes of the mechanical, like a lumbar strain, degenerative disease, maybe osteoporosis, congenital disorders. Non-mechanical, they are very important. We should know the neoplastic, especially in elderly patient, the multiple myeloma, lymphoma, metastatic CA. Infection should be always considered in any patient who is complaining of back pain. The septic discitis, paraspinous abscess, and being a physician, we should much more concentrate on the visceral diseases that may present with a back pain, like prostatitis, renal disorders like pyelonephritis, nephrolithiasis, the GI diseases, aortic aneurysm. So all these things should be considered in any patient who present with back pain. Briefly going into the detail of mechanical back pain, is all you know is mostly common in the young age patient between 20 to 55 years of age, and it's because of the heavy weight lifting or bending or improper position of the patient. It may be asymmetrical, and it's the pain which is aggravated by the activity. These are very key points regarding the history of your patient who has a mechanical back pain. So it aggravates with the activity and relieve with the rest. So only one simple question we need to ask from your patient, and it rarely radiates below the knee. And usually the prognosis is good. These pain usually get improved in 30% patient after 2 days, and it's by the 6th week, 90% they recovered. The psychological elements like the job dissatisfaction, anxiety, and the depression. Maybe some of these patients, they present to you with a chronic back pain. The history and examination, and now the alarming symptoms should be asked. What are the alarming symptoms? Like previously was saying, then infection. So infection, you need to ask about the fever, any wrist pain, any recent infection in the form of UTI, and the history of immunocompromised state, or the IV drug abuser. For cancer, as we all know, the unexplained weight loss is the most important thing you need to ask from your patient, and the pain at rest at night. A pain which works more in the night while lying down should always be taken seriously, and it may be the only alarming symptoms of your patient. So the cardiac angina is a neurosurgical emergency, so you need to know about the urinary retention. So you need to ask about the bladder and bowel involvement. So the neurosurgical emergencies, that should be evaluated properly. Like in the form of the cardiac angina, you need to ask from your patient how the pain started. If there is any involvement of the bladder and bowel, if there is any evidence of central anesthesia, and how it started, when it started. Okay, thank you. Sorry for interference. Now, the back pain due to vertebral fracture, the risk factors are aged people who are more than 70 years of age. They are at a more risk of osteoporosis, the trauma, or the use of the corticosteroid. Inflammatory back pain is the pain which improves with activity and which works with the rest. So you need to ask from your patient whether the mechanical pain gets worse with the activity and it will decrease with the rest. The inflammatory will worse with the rest, aggravated by the improve with the activity, and the malignant, the pain which is because of the malignancy is always worse at night and get worse. The degenerative disc diseases and the spondylolisthesis should always be considered. Back pain. This is a very important thing. Maybe the presenting symptoms and the serious medical problem like a peptic ulcer disease, the patient can present, maybe abdominal aortic aneurysm, and the kidney stones. So most of these patients, they come with a backache and usually has been wrongly investigated with MRI, unnecessary, and maybe a pancreatitis. You keep a very low threshold for diagnoses these serious medical issues. The physical examination is absolutely important, and this examination is not to find out the cause, it's to identify the features which may indicate any more further investigation, whether it is important or not. And this examination can be done in standing by just looking at the posture of your patient, and the active range of motion of the lumbar spine can be assessed. And then the sitting, examine the motor sensory examination system should be examined, and reflexes. Then the spines, so spine should be examined, like the rotational range of motion at the hip, straight leg rising, and pediatric test should be done in order to find out whether it's a neurological pain or not. The prone position in order to look for the spine and sacroiliac joint tenderness, reverse straight leg rising test, and then the cardiac angina, if suspected, do the rectal examination. Malingering, you may come across a lot of patients who may be complaining of chest pain, and there may be a vital sign may be positive, the straight leg rising test may be positive, but once you distract that patient attention so that pain usually get disappeared and the straight leg rising test get improved. This is very important. As we all know, in our practical life, whenever I come across a patient who complaining of back pain, none of us are going into too much into the detail of that, the history and examination, and straight away advising imaging. So imaging is not indicated in each and every patient. It should be used in a patient who has been properly assessed. And for assessment, the most important thing is the history and examination. In the absence of any alarming red flag signs, which we have already discussed for the infection, malignancy, and cardiac angina, the patient don't need imaging in the first 6 weeks. And approximately 1/4 of patients with acute low back pain underwent imaging who don't have any identification necessary for them. This is the American College of Physicians and American Pain Society. They recommend that the clinician should not routinely obtain imaging or other diagnostic tests in a patient with a non-specific low back pain. Even in the NICE guidelines, they are advising the clinician should not routinely advise the patient imaging until and unless there is some specific indication in the form of you're suspecting some infection, malignancy, or some cardiac like medical emergencies. The earlier use of imaging without associating symptoms is not associated with improved outcome, but it usually increases the use of invasive procedures and healthcare costs. So that's very important thing to understand, because the unnecessary imaging may increase the patient worry. They will go for more and more investigation, and more it will lead them to more and more costs. So we need to select our patient very properly for any imaging. There is an observational study in a patient more than 65 years of age with the back pain without radiculopathy. There were no difference in the disability. At 1 year follow-up of these patients who have imaging or who don't have imaging at the initial presentation. Imaging often shows abnormalities in adults with or without a low back pain, which makes it difficult to determine which imaging findings are clinically important. Very important data has been collected here. So they are saying that the disc herniation is 21 to 67% of asymptomatic adults में भी होते हैं, and the spinal stenosis जो होती है in 21% of asymptomatic adults over the age of 60 years. So they unusually the patient undergo surgery. In these patients, the imaging is absolutely not indicated. Even when the radiographic findings are consistent with the clinical presentation, the magnitude of the radiographic finding doesn't necessarily correlate. This is the most important thing. The patient who requests imaging, the counseling. You need to counsel your patient about the disease nature, their presenting symptoms. So all the patient assurance is very much important. The accidental imaging findings may further aggravate your patient worries, and we will go for unnecessary investigations. Careful physical examination of your patient is absolutely mandatory. In all the patients who present with back pain, history and examination is important. Until and unless there is a red flag sign, so symptoms, so you are not supposed to advise the imaging. This is a very busy slide, so we are running short of time. So this is an algorithmic presentation of acute back pain assessment. Any patient who has the retention of the urine or outflow incontinence, so this is a neurosurgical emergency. That's the case where a cardiac find. So we have already discussed, so do an MRI. If the risk of cancer is there, so go for the imaging. If the risk of cancer is moderate to high, so go for the plain radiographs and inflammatory markers in the form of ESR and CRP. And if that is high, so it's okay, go for the infection, and otherwise just do the MR if that is no. So we are running short of time. So subacute pain assessment, low back pain assessment, any patient who is not recovering after 6 weeks, so you reassess your patient. Why your patient has a back pain, and if the patient, there is some alarming symptoms developed by that age, so you can go for imaging. Similarly, for chronic back pain, which is more than 12 weeks of duration, should undergo the risk assessment for acute and subacute, and in that case you reassess, examine your patient, and if there is any alarming signs, symptoms, and the new science has developed, so you can go for this. This is AHR criteria for that. Imaging in acute back pain, like possible fracture in the form of major or minor trauma, possible tumor or infection. A patient is more than 50 years of age and less than 20 years of age, or has any history of cancer. There is constitutional symptoms, or the patient is immunocompromised, like using IV drugs, immunosuppressant therapy, and patient has any nocturnal pain. So this is important, the nocturnal pain. Always keep on taking a very good history. Detailed history is important. The imaging, plain imaging, like in the form of plain radiographs, the AP and lateral, you need to look for the vertebral complex fracture. MRI in the form of the spinal stenosis, cord compression, nerve root compression, inflammatory changes, and malignancy. For most patients with a low back pain who require advanced imaging, the lumbar spine MRI is generally the best examination. So the bone scintigraphy or CT scan in the form of fever suspecting metastatic diseases, routine biochemistry and hematology like ESR and CRP. Don't underestimate these investigations. So very important thing, if they are raised and you're suspecting infection, so go for the imaging, and if they are normal, then you need to do the reassessment of your patient, protein and urine electrophoresis in the form of the myeloma and the PSA for the prostatic CA and elderly. EMG and NCS is useful in assessing the nerve compression symptoms for which are more than 4-6 weeks. Briefly going through the management, because we have already short of time. So non-pharmacological treatment is the key in the mechanical back pain. Education of the patient is important. You need to explain to your patient why you have symptoms and how to help your patient. Then there is a proper lifting technique should be advised for your patient, and the smoking cessation is important, and improvement in the posture like the chair, the standing desk, and the physical condition, and the modification of the activities to decrease the physical strain. Psychological therapy, complementary therapy, these are different type of therapy. The physical therapy, the heat and cold treatment, symptomatic treatment, and there is no long-term benefit in these things. A multidisciplinary approach in the form of the patient who is having a chronic pain, like a physical, psychological, and the social aspect of the patient should be advised. Limited role of these NSAIDs, steroids, muscle relaxant. We can give opioids for very short term. Chronic neuropathic pain, so you can give gabapentin, duloxetine, and TCAs. And surgery, it has a limitation like patient selection, very clear indication of the surgery. Specific surgery is recommended. Surgery is not recommended if there is only radiographic abnormalities and your patient is asymptomatic. Progressive spinal stenosis in the form like the spinal cord compression, you can go for the surgery. And the complications, what the surgery complication could be, the patient may have a persistent pain, may have infection at the site, and may have a non-union. The patient may develop DVT, cutaneous nerve damage, or there may be implant failure. So the take-home message is, for me, only this one line is very much important: the history and examination. Give your patient a time to examine, to take a very good history, and then to examine your patient in very detail. This is the most important thing, because the trainees may be sitting here, so on their part, any trainee who is deficient in history and examination, they can't be a good consultants. So take a very good history, do very hard work on your history and examination. Unnecessary imaging, it increases your patient worries and it increases your patient cost. MRI is indicated only in a very specific cases, is not indicated in each and every patient. And another take-home message is that every backache patient is not a candidate for MRI. So every patient with a backache should not be undergo MRI. So thank you so much, and I'm sorry I have taken too much time because there was a lot of slides. So thank you so much.